They also are training some PAs and nurse practitioners to provide formal presentations, and that will help maximize reimbursement. And now their asthma education visits are part of their critical pathway for newly referred children with asthma. And along with these asthma educators, they are providing an educational core for a successful inter-city asthma education and awareness initiative in the city of Atlanta. So what are the results? That patient outcomes along with cost savings have been achieved with asthma education provided by certified asthma educators throughout the country. And we look for a few minutes at what the evidence is. Well, it's still emerging. You know, if you look for some studies that are out there, does it make a difference if you're a certified asthma educator versus not? You know, we just don't have enough studies yet, enough data to indicate that it does. We know anecdotally it does. We know in our neck of the woods it does. We don't know nationally. So we're still looking at that. But the Asthma Regional Council of New England has created some wonderful documents. And one of them is Investing in Best Practices, a business case. And I think that's on your flash drive. And we are one of the examples in there, but there are other examples that are published studies that have shown the benefit of home-based asthma education and just general asthma education services. They also created Asthma, a business case for employers and healthcare insurers, how to sell your story to health plans, you know, how to create your business case. And then also insurance coverage for asthma, value and quality checklist for purchasers of healthcare. So it has some wonderful documents that should be on your flash drive, and you might start there anyway. And if you have questions, they do reference the asthma programs that they used as examples in these documents. They're wonderful resources, and I suggest that you start there. There's also a quote in one of these documents: at a population level, it is best to align insurance coverage with recognized best practices, especially when they are proven to promote value-based care. And I think that's what you're going to find in many of these documents. You're going to see what are the best models out there, what are they accomplishing, what's return on investment for your payers, and who can they contact for more information. And that's all in those documents. So what are the best practices in asthma? Well, they're all in the guidelines. That, as you all know, everything we do, everything we say is all predicated on the guidelines. When I go into physician offices and I have some of those complex tables that come from the guidelines, you know, I say these are not the guidelines according to Karen. These are the guidelines according to the National Institutes of Health. These are the clinical practice guidelines. These are the best evidence we have out there. These were written by a panel of experts who pulled from data from 10 years worth of research. So this really is the state-of-the-art best practices for asthma as it stands today. And a lot of that is really predicated on those 6 key messages. Are you familiar with the Guidelines Implementation Panel report, the GIP report? This panel knew that very few primary care providers were going to download, as Dr. Teach said, 480 pages. You know, take a whole ream of paper to print the guidelines. I've done it. Got one of those 4-inch binders with the guidelines in it, or even the 80-page summary. You know, if you are a primary care provider and asthma is just one of the many chronic conditions you're dealing with behavioral health, and you're dealing with diabetes and hypertension and everything else. So asthma is just one of them. But if they remember nothing else than these 6 key messages, if every primary care provider in the country made sure that they were adhering to the 6 key messages, you know, asthma would be much less of a problem than it is today. So most important, inhaled corticosteroids are the most effective anti-inflammatory medication for long-term management of persistent asthma. And all patients with asthma should receive a written asthma action plan, initial assessment of asthma severity, review the level of asthma control at every follow-up visit, periodic follow-up visits at least every 6 months, and then assess for exposure and sensitivity to allergens and irritants, and recommend ways to reduce those relevant exposures. So this really is the heart and soul of the guidelines right here, if they remember nothing more than this. And one of our payers in West Michigan has actually incorporated some of these into their physician incentive program. So they pay physicians to do the right thing. They pay them, it used to be they would pay them based on the ratio of long-term control to quick relief inhalers, and that wasn't working very well. So now they're paying them for meeting certain criteria, like, are you doing spirometry in your office? Does every one of your patients have an asthma action plan? Are you doing routine follow-up visits at least every 6 to 8 months? Are they getting flu shots? Are your kids with asthma getting flu shots? So if they meet those 4 criteria, they're getting a set dollar amount per member per month for those members that they're meeting. So it really is becoming part of their core services. The evidence also includes the 4 best practices for improving asthma outcomes, and that again is using spirometry to assess disease severity and control, environmental control measures to avoid or eliminate triggers, comprehensive drug therapy to reverse and prevent airway inflammation and constriction, and patient education that fosters a partnership among the patient, family, and clinicians. So there are some published studies out there that I'll just touch on very quickly. Bolton was a randomized controlled trial looking at 3 one-hour group sessions to high-risk adults by a nurse. It cost about $85 per patient, reduced ED visits by 59%, and they saved $22.50 in healthcare costs for every dollar spent. Clark was another randomized controlled trial, looked at 6 one-hour individual sessions with high-risk kids. Cost a little bit more expensive here, $1,558 per patient. Again, reduction 58% in hospitalizations and 59% in ED visits, and they saved $11.22 in healthcare costs for every dollar spent on that program. Grenadier was a randomized controlled trial, and that involved comprehensive management services for high-risk children and education provided by a case manager, and the cost there was $190 a patient. That reduced ED visits by 57% and reduced hospitalizations by 75%, saved $9 for every dollar spent for the case manager. And finally, Troutner was not a randomized control trial. It was a pre-post intervention, which is how we conducted ours too. And that was education delivered by a specialized nurse to high-risk adults with asthma while they're in the hospital. The cost there was $233 a patient. It reduced missed work days, physician visits, and asthma attacks, and saved $3 in healthcare and lost work days for every dollar spent. This is all in your flash drive too. So these are, you go to your payers and say, we've got a program that works and we've got data that can show you that this can save dollars. You know, the data are out there. But there's other reimbursement models around the country too that are just starting to crop up. There's just different pockets of reimbursement that are just starting to crop up right now. So it's a really interesting time. In Minnesota, 2004, they looked at their Medicaid members. Education was provided in individual or group setting. The instructors in this instance have to be AECs, and the course content was specified. They did recommend pre and post tests, and they did bill for new patient sessions. They were allowed to bill 10, and for an established patient, they had 3. And they billed with a HCPCS code of S9441. And in the state of New York, the executive budget was amended in 2009 to require asthma and diabetes services for Medicaid clients. And the one providing that was an AEC who is working under a Medicaid provider. This is for individuals who are newly diagnosed or complex condition. They were allowed 10 hours over 6 months. Medically stable, they were allowed 1 hour in 6 months. And you can see the CPT codes there. They were all for 30-minute sessions. State of Massachusetts in 2010, they also enforced or passed a law mandating a global or bundled payment system for high-risk pediatric asthma patients, and that covers patient education, environmental assessment, mitigation of asthma triggers, and purchasing of DME equipment like nebulizers, spacers, that sort of thing. And they piloted that in communities with the highest rates of asthma. So it's a mandate right now for a limited amount of time. After 2012, the future is unclear. It depends on what outcomes they see, whether it's going to continue or not. And that's it. I believe leaves us about a few minutes for questions, so thank you very much for your attention. I appreciate it. Question?
I got a question about the startup of the organization. You said it was grassroots. Was it nurse-driven, or did you have a medical director? And
we did. We had a medical director. We actually had a physician who at that time was a pediatric residency program director for the Children's Hospital. And then we had a nurse who was doing asthma education in another hospital. And it was just a collection of individuals in Grand Rapids who were passionate about children and pediatric asthma, and were highly concerned about the increasing prevalence and morbidity and mortality rates. So they got together and they said, okay, and I talked about this at the EPA, but they literally said, you know, we're here because we're all passionate about pediatric asthma. We're not here to promote our institutions. And they had a box outside the door, and they said, everybody leave your badges at the door. And everyone took off their badge, put it in the door, and then they came in, and they were all there because they were just champions because of pediatric asthma. And they talked about asthma, what they could do, and they formed this coalition. And they, for 2 years, primarily did grand rounds and some professional education. After 2 years, they said, we really are just touching the tip of the iceberg. We want to provide a direct service and really get into asthma and where it lives in our community. So that's when they talked about creating this model. It was just a pilot demonstration project for the first year, and we had a medical director, and we had the nurse who was doing asthma education at one of the hospitals, because they said, well, who does asthma best? Well, the competing hospital did. Didn't matter. It didn't matter. They were, great competitors. That's where asthma was that's where people were receiving asthma education in our community. So that nurse took the reins there. I was hired then 15 years ago as one of the nurses making those visits, and that's how it started. It really was a grassroots effort, and we got funding that first year from the 3 acute care hospitals in our town who were very much competitors, and then 2 local foundations. They gave us our seed money, about $120,000 that first year, just to get us going.
For your home visiting program, what is your case capacity, and also what is the cost per client?
Good questions. Capacity for a full-time educator, they have a capacity, right now they have a goal of about 60 clients in each. Really, we're looking for more clients. They're not always full, their caseloads are not always full. They could probably take up to about 70 total for a full-time FTE. And what was the other question you had? The cost. Yes. Well, an interesting story there. We were billing what the going rate was for a Medicaid case, the Medicaid visit for skilled nursing care. So, in Michigan, the going rate for a skilled nursing visit for Medicaid is about $85. So we were billing that because that's what they allowed. And we billed that for the first couple of years, and then we went to the health plan and we said, this is really costing us a lot more than $85. Would you give us more money? And they said, but that's what you're billing, so obviously that's what it's costing you. Well, we didn't, again, we were naive, we didn't know. They said, well, what physicians do you know that bill what we're allowed? They all bill their actual costs. So then we went back and we looked at our costs, and we took our overall budget, which includes the infrastructure, the superstructure, it includes, our biller, includes mileage, cell phones, everything else, all of our other expenses, and it actually came out closer to about $205 a visit. So that's what we bill. Now, we still get the $85 or whatever it is that they're giving us at the time, but now we can go back to them in a year or so and say, we can demonstrate a loss, and then we can negotiate for a higher level of payment. Yes?
Are the community health workers, are their visits reimbursed?
They are not right now because our payers are telling us they will only reimburse for certified asthma educators. However, when I was at the EPA forum, I heard that there are quite a few communities that are starting to reimburse community health workers. So if that's the case, we're losing a lot of revenue because they make a lot of visits. So we are definitely going to look into that. Yes?
I have another question.
Sure.
As far as getting certified, do you have to have, you said if you're not a clinical person, you have to have 1,000 hours. If not, then do you demonstrate that you work with asthma patients?
You have to just demonstrate that you have 1,000 hours of direct patient level experience.
Okay.
So, that would probably be a half-time person in the course of a year, 1,000 hours or several years, but you just have to have that 1,000 hours of experience. So that means that it can't be someone who is just educating physicians or educating other health professionals. You actually have to be educating patients. And if you have 1,000 hours of patient level education experience, then you would qualify to sit for the exam.
Currently, are you working with payers, with Medicaid, managed care, commercial groups, the gamut currently?
Yes. And yes. So most of our payers are Medicaid plans. One of the payers, Priority Health, has 3 different arms. They have Medicaid, commercial, and Medicare. So they paid us for Medicaid first, and then they said, well, we've got some commercial patients too that we're happy to pay you for, even at a higher rate, because they may not take 18 visits, and oftentimes they don't. They just take a handful of visits and they're good to go. And they said, we've got some, elder folks in Medicare, and they need help too because they have asthma. So we signed a contract with them for their Medicaid, the Medicare arm. And so now we're serving all of those members. But most of the other payers are Medicaid.